This video serves as a guide for therapists treating patients with sleep insomnia disorder. Insomnia disorder is characterized by persistent dissatisfaction with sleep quality or quantity. This can include difficulty falling asleep, difficulty staying asleep, or waking up too early and not being able to return to sleep. Importantly, these symptoms occur despite having adequate opportunity and appropriate conditions for sleep. So it's not just about staying up late by choice. It's about wanting and trying to sleep but being unable to. The key word here is persistent, meaning that it continues over time and causes distress or impairment. The DSM 5 does not view insomnia as simply a symptom of another disorder. Instead, it recognizes that insomnia can occur independently or alongside medical or psychiatric conditions. This reflects a more modern understanding that insomnia is often its own disorder with maintaining mechanisms. The most widely accepted explanation is the 3P model proposed by Arthur Spielman, which describes insomnia as developing through predisposing vulnerabilities being triggered by a precipitating stressor and then maintained by perpetuating behaviors and thought patterns. A formal diagnosis of insomnia disorder, the DSM 5 requires more than just occasional poor sleep. The person must experience persistent difficulty falling asleep, staying asleep, or waking too early. These symptoms must occur at least 3 nights per week and persist for at least 3 months, which qualifies it as chronic. Importantly, the sleep disturbance must cause significant distress or impairment during the daytime, such as fatigue, difficulty concentrating, mood disturbances, or reduced functioning. When we think about insomnia, it's important to recognize that it really is a 24-hour disorder. While the symptoms occur at night, the impact shows up during the day. According to the DSM 5, individuals often experience fatigue, low energy, difficulty with attention and memory, mood disturbances such as irritability or anxiety, and declines in social, academic, or occupational functioning. Research also shows that insomnia increases the risk for conditions like depression, anxiety, PTSD, and even substance misuse. So, insomnia isn't just about sleep, it has broad psychological and functional consequences across the entire day.
These here are two complementary assessment tools. The Insomnia Severity Index is a 7-item self-report that measures sleep difficulty, stress, and functional impact. It gives a severity score which aligns directly with the DSM criteria, especially when the requirement for daytime impairment. The sleep diary adds behavioral precision, which is collected daily over the 1 or 2 weeks, and helps track bedtime, wake time, time to fall asleep, nighttime awakenings, and total sleep time. From this, we calculate sleep efficiency, total sleep time divided by the time in bed. Efficiency below 85% often indicates insomnia. As outlined in the CBT I primer, this diary-derived averages guide sleep restriction therapy. The diary moves us from subjective complaint to observable pattern. It reveals mismatch between sleep opportunity and sleep ability. Once we can see that mismatch clearly in the data, the next question becomes, how did it develop? That's where the 3P model explains the progression from acute stress to chronic insomnia. Most insomnia begins with a stressor, illness, work pressure, relationship disruption. That initial sleep disruption is normal. According to author J. Spielman's 3P model, chronicity develops when individuals compensate by extending time in bed, sleeping in, or napping. These behaviors reduce homeostatic sleep drive and fragment sleep. Over time, the bed becomes conditioned with wakefulness, stimulus discontrol, and sleep-related worry increases physiological arousal. At this point, insomnia is no longer driven by the original stressor. It's maintained by behavioral and cognitive adaptations. That shift is what makes it modifiable. Now that we understand how insomnia becomes chronic through conditioned arousal, reduced sleep drive, and cognitive worry, CBTI directly targets those mechanisms. CBTI is not just sleep hygiene, it's a structure mechanism driven intervention with stimulus control therapy, which reverses stimulus discontrol by reassociation with sleep, sleep restriction, guided by the sleep diary data, corrects mismatch between sleep opportunity and sleep ability, and cognitive restructuring targets catastrophic beliefs, reducing cognitive arousal. Finally, relaxational techniques lower physiological hyperarousal. Sleep hygiene supports behavioral consistency, but it's not sufficient alone. Meta analytic evidence from Art Van Straten et al. From 2018 shows CBTI produces large and durable effects. So CBTI works because it directly affects and reverses the perpetuating mechanisms we just discussed.
For sleep insomnia treatments, there is the four treatments that we want you guys to know for CBTI. First one will be stimulus control therapy. Stimulus control therapy, also known as SCT, is a behavioral strategy designed to reassociate the bed and the bedroom with sleep. Instead of wakefulness and arousal, the core rules are practical. Go to bed only when you feel sleepy, and use the bed only for sleep. If you can't fall asleep or you are awake and starting to feel frustrated, get out of the bed and go to another room. While you're out of the bed, do a calm, low stimulation activity and avoid activating behaviors. Return to bed only when you feel sleepy again, and repeat as often as needed during the nighttime. Something to keep in mind: wake up at the same time every morning and avoid napping. Finally, safety comes first. If leaving the bed isn't safe or feasible, we modify the plan. Second is the cognitive restructuring. This targets the sleep thoughts that keeps insomnia going, especially the thoughts that spikes anxiety at night. A common example is, if I don't sleep, tomorrow is ruined. And that kinds of worst case thinking can rise arousal and make sleep harder. So we use a quick structure. First, identify the situation like lying in bed awake. Second, write the exact automatic thoughts. Third, label the emotion and rate how intense it is. Then we do a reality check by questioning the thoughts and checking the evidence. Is there another more balanced way to see this? Next, we replace the original thoughts with a more realistic, believable statement, something like, tomorrow may be harder, but I can still function. The goal isn't positive thinking, it's lowering the arousal by making the thoughts more realistic. Third is relaxation techniques. The goal here is not to force sleep, it's to lower pre-sleep arousal, tension, worry, that racing mind's feeling. They are nighttime tools used when someone is getting ready for bed, and they also make it easier for clients to follow the behavioral parts of CBTI. Common options include breathing exercise, mindfulness, PMR, body scan, guided imagery, and grounding. Clinically, the best approach is to pick one method the clients will actually do, practice it briefly, and keep it consistently so it becomes a reliable downshift tool at night. Fourth is the sleep hygiene, helpful but not enough by itself for chronic insomnia. Sleep hygiene is basically a short list of behavioral and environment changes that reduce sleep disruptions. On the behavioral side, caffeine, nicotine, and alcohol limited naps. Keep a regular schedule and getting daytime activities or exercise. On the environment side, manage brightness, temperature, noise, and electronics, especially screens near bedtimes. The main clinical point is this: don't overwhelm clients with a long list. Choose 1 to 3 changes that fit their real lives and pair those with core CBTI skills for the best result.
While CBTI remains the gold standard for treating insomnia, therapists should be aware of adjunct and alternative options. Relaxation techniques and sleep apps can provide accessible non face to face tools such as trackers, music, and guided mindfulness. These may help reduce hyperarousal but are typically not sufficient as standalone treatments for chronic insomnia. Acceptance and commitment therapy for insomnia, or ACT I, shifts the focus from controlling sleep to reducing the struggle with sleep. However, current evidence still supports CBTI as the most robust and effective intervention. Insomnia can occur independently but is also frequently comorbid with medical and psychiatric conditions, so assessment is critical. As therapists, our goal is not perfect sleep. Variability is normal. Instead, we teach clients how to respond effectively to poor nights without reinforcing maladaptive patterns like extending time in bed or panicking. CBTI works because it builds behavioral consistencies and cognitive flexibility. Ultimately, we are helping clients develop long term confidence in managing setbacks, not eliminating every bad night.
I don't know why I can't sleep. I just lie there scrolling on my phone for hours.
How long do you think you're on your phone in your bed?
Sometimes an hour, sometimes more. It helps me wind down.
The tricky part is that your brain is learning something important during that hour.
Like what?
It's learning that the bed is a place for being awake, stimulated, and engaged, not sleeping. The light from your phone also signals your brain to stay alert.
So my phone is basically training me not to sleep?
Exactly. In CBTI, we use something called stimulus control. The goal is for your brain to strongly associate your bed with sleep and only sleep.
So what do I do instead?
Starting this week, your phone stays out of the bed. If you're not sleepy yet, stay in the living room and scroll there. Only get into your bed when your eyes are heavy and you're ready to sleep.
And if I wake up and want to check it?
If you're awake for more than 20 minutes, get out of bed, but don't scroll in bed. We're retraining your brain that bed equals sleep, not screen time.
That's going to be hard.
It might be at first, but this is one of the fastest ways to rebuild healthy sleep.